Good morning, Dr. Harrison. I'm so excited to have you on here. It was a pleasure to be able to meet you in person. Gosh, was that last month, beginning of April, down in Florida at Sleep Group Solutions. So welcome.
Thank you. Good morning. Happy to be here.
Awesome. Yeah, I'm so excited to have you on here to hear all about the EchoVision system, everything that it can do for our patients, for our practices, practice growth, and things like that. So let's just start off if you want to tell us a little bit about yourself, your background, and what kind of got you shifted into airway dentistry.
Well, I think I came at this a little backwards compared to normal people. So I've been a dentist for almost 30 years now. And I was fortunate to go to a hospital residency out of dental school. I really was wanting to be on the path to oral surgery. I wanted to fix faces and do jaw surgeries. And so, my original thought process is, there's so many crowded teeth. Let's just do orthodontics and uncrowd them. But like for some people, the jaws were in the wrong place. So let's just cut them apart and put them together differently. And so I got to go do that. And about halfway through that year, I realized that, all I knew for my first 23 years of life was school. And I thought, I need to go make some money. So I went to a dentist in my hometown, and I got a job there for probably about 3 months. And 3 months into it, I knew it was not the right fit. And so I think the day I went in, about 6 months from the day I started, I was going to quit. He was ready to fire me. So it all just it worked out. But that landed me in Colorado. And when I moved to Colorado, first I saw there was an ad, and a guy who says, looking for a dentist. So I called him up. I said, before I drive out there, I just want you to know, I'm coming out of one bad associateship. I want to not repeat the same mistake twice. So I just got to tell you off the bat, like, I'm left-handed. He says, wow, I'm left-handed too. And he goes, I've got to tell you something. I'm a pediatric dentist. And I'm like, whoa. And he goes, but I own a family I practice, and I only want to see the kids. And I said, well, this is great. And so I went out there. We worked together great for 3 years, and I started to learn functional orthodontics. So this is like in the mid 90s. And we didn't know we were like being airway dentist, but we started to see all the things that, now that I know what I know, I kind of put the pieces together backwards. And, all the kids that we were uncrowding teeth were just starting to sleep better and behave better and do better in school, and not have the common problems that all the listeners on this podcast are probably aware of. Right. And so that went on for several years. And then I came across some goals that I'd written down on first day of residency, and all of them were checked off except own my own practice. So I approached him and I said, would you like to sell half the practice? And we met with this consultant, and he said, basically, he's been a missionary overseas for like 30 years. So he had no retirement. He says, you can't give up any profitability. So he's like, well, I've been looking at a second location. And at this time, I think he was in his early 60s. He's like, I don't have the energy. You're young, you're vibrant. Go here, build this office. When you're on your feet, then just go up there and take off. And so I did actually hang a shingle, back in the days. I don't know if you could still do it today, but we were getting so many new patients right out of the gate, and technology was my niche. So I was one of the earliest people to have lasers in practice. I was one of the earliest people to have cone beam, digital x-ray, digital charting. And so that was my niche, right? It's going to be experience tomorrow's dentistry today. Mm-hmm. In that process, then the lasers led to tethered oral tissue releases. It's really sad, Brittany, that Myo wasn't a bigger part of my career. I think, talking with Kevin Boyd, he had a very similar path too. It's and Ben. It's it's hindsight's always 2020. I knew of it. I just didn't know where to find anybody. Right. And I think that's still a challenge that a lot of dentists perceive that it exists. And it's podcasts like this and Airway Health Solutions meetings that we're really growing. Mm-hmm. Fast forward a little bit to speed up the story here. I realized early on that surgery wasn't always the fix. And I think that ties into the Myo. philosophy is
Absolutely.
you've got to train these muscles before you do the procedure, and then you have to exercise the muscles after the procedure, or you're setting yourself up for anything, really. I wouldn't necessarily say failure, because I had a lot of successes, but predictability. Originally, I'm from Missouri, so that's the show me state. So usually before I do anything, you've got to show me. And that's what we're going to do this morning on this podcast. I know you've got an audio version of it too, so I'll do my best radio broadcast announcer to explain what we're viewing that the others can come back and see later on. Hung the shingle, got out of the associateship that was working really well quickly, like under 6 months. I was getting 100, 150 new patients a month, maybe more, but never less than 100. And so 6 months into it, I had 600 patients. I was working with practice consultants, and they said, the average practice, it's 1,200 patients that step foot in the office every 12 months, at least once per doctor. And then you need 2 hygienists for every, 1 hygienist for every 600. Then you need 2 assistants so you can bounce between chairs. And I never really liked bouncing between chairs. I was more of a, one at a time and just do a bunch of dentistry versus turn and burn and run from room to room. When I had days like that, I was so tired when I came home. I was just like, I can't do this. I became one of the earliest masters in laser dentistry. And so that led me to being a speaking career and an educator career for a laser company out of California. Run a group on Facebook of, I think we're up to like 26, maybe 2,800 members in that on laser dentistry, 125 countries. So I had this big reach. I was practicing 3-4 days a week, and I was lecturing 2 days a week. And then I would travel on the off days. And so I did that for a long, long time. And really in 2015, just started to burn out. It's like something's got to give. Either, I got to give up speaking and teaching, which I love. I like to influence people to do better. I think, we don't know what we don't know. And we should always be learning. Had the chance to study under Spear and Gordon Christensen and like all the gurus. So you start to feel old when all of your mentors are no longer around, or they've passed the baton to other people. But it's exciting because really, I guess being kind of airway centered in the beginning was a lot of arrows in the back. Honestly, it was different, but I knew it was the right thing. So I just stuck with it. In 2017, I just kind of gave up. And I'm like, I've been doing this a long time, and there's just not enough people that are following. And I just wanted to see my kids grow up, honestly. So I retired, sold the practice, sold the house, moved up into the mountains, and hid out for a few years. But then Sleep Group Solutions found me. I was in Florida for a sleep conference. And they said, would you like to come be the Western Regional Director? So I was managing 10 Western states of the US. So since I live in Colorado, basically just go straight west out to Hawaii, up to Alaska, circle your way back. But with the laser background, I had so many friends, in different areas of the country that we were able to put Sleep Group Solutions program into those practices. And so July 1st of 2021, I became the national director. So now I get to travel every week pretty much all across the US and help dental offices that want to get started in dental sleep medicine, get started on the right foot. Like, don't reinvent the wheel. It's a turnkey program. It's a solid technology, and it's getting picked up by, people that certainly the orthopedic solution is in my opinion, addresses the root cause, and you really want to go that route when you can. Unfortunately, not all of our patients make the best decisions. And so oral appliances are still a thing that we need to learn about, but we want to mitigate side effects. And I think that's really what the EchoVision technology showcases is maybe, and research is showing that as little as, less than 1 millimeter of jaw in the wrong position will have a huge impact on airway for some people. Now, other people have this big zone of adaptability. You could put anything in there, and that's why dentists that just make a device or have the lab pick the bite position, which just applauds me. It works sometimes. And so there's some confusion out there. And I think that's what I want to get out of this podcast, is put a little bit of clarity into what this information means and what do we do with it. So I know that was a long intro, but there you go.
No, thank you. I love hearing your journey. That's an incredible journey. One of the things that I was reading when I was looking through the EchoVision brochure and the website and things like that was how it can even help sleep dentists rule out patients who maybe aren't really, the oral appliance isn't going to work for. And I think that's great, because I think sometimes some providers could get just a little happy and want to make an appliance for everybody. And really, it's not a one size fits all thing. So to be able to have this, diagnostic tool that can help kind of weave that out is great, right? And then also to be able just to get that report and know exactly what's going on. So everybody obviously would have heard your bio at this point and hear you talking, but if you want to give everybody a background on just the EchoVision, what it is. I don't know how long, how familiar you were with it prior to being with Sleep Group Solutions. Were you always using a Rhinometer, or how did that work?
No. So I always come at things backwards, it seems like, right? So one of my favorite lessons was Frank Spear, and I think he talked 2 or 3 days on all of his mistakes, or his major mistakes. It's
important. We totally learn from our mistakes. That is for sure.
And it's better when you learn from someone else's mistakes. So a brief history of EchoVision. It's been around. Well, let's back up even more. It started with rhinometry, which is really, I think, the bulk of your interest. When I was in Florida last month with you, that group was all about rhinometry, and it stemmed from an orthodontist friend of mine, client up in northern Idaho, Brett Christensen. And that's really kind of, I think, how our paths crossed, right? But the rhinometer was used in otolaryngology. So as ENT, it was medical technology, and it was a measuring tool, to assess size and distance within nasal airway. In the 90s, there was a dentist in the Northeast who said, well, why don't we make one that goes for the oral pharynx? Because a lot of people do mouth breathe. And we know that sleep-related breathing disorders is a problem of collapsibility. But if there was a way to test different jaw positions, we call them titrations, although I don't like that word because it's really associated with CPAP, but test different jaw positions to find if there's one that's more favorable than another. And if we can change the vertical, what impact will it have on this patient? Because would you be more comfortable with your jaw just slightly more open, or open at one level, but then shut your jaw way out like a bulldog?
Right.
And that information, and I agree with your statement, knowing who you can or cannot help is probably one of the first and most vital uses of the technology. But a lot of dentists, they don't use it enough. This is something every appointment you really could assess the patient, because it takes seconds. It's quick, it's painless, there's no radiation. It's just sonar technology. So it's sending sound into whatever it's trying to measure, and it's listening for it to come back. So that's where we put the name EchoVision on it. So it started as the Rhinometer, then a dentist added the Pharyngometer to it. And in 2005, Sleep Group Solutions bought the patents to it, and we rebranded it as EchoVision. Now, I will tell you, I didn't use it in my practice. I did it the hard way. I wasted a lot of chair time. I really cut into my profitability. I treated people that I really had no business of trying to help because they weren't a candidate. They had a concentric collapse. And when I saw it presented, I actually stumbled upon our chief strategy officer now, John Nadeau. He was given a lecture in a room in Huntington Beach, California, right before me. And as a professional speaker, one of the tricks that we learn is sit in the room before you're on stage. So, you know, who's in the room, who stays, who's nice, who's friendly, who do you not want to make eye contact with because they'll throw you off of your talk track? Is there a problem with the sound? You know, is there a problem with the screen or the lighting in the room, and correct it before you're on stage. So it makes you more presentable and really puts on a better show, right? And so he had this Echo Vision of the time, it was 2015, on display. And I looked at it, I'm like, it looks like something I would have built from Radio Shack parts, you know, when I was in middle school. And I'm like, there's no way I'm putting that in my technology driven practice. You know, I've got lasers and cone beams and CAD CAM and like everything, all the toys. I had all the toys, anything. And this was Gordon Christensen, anything that makes my job easier, the patient's experience better, has a return on investment. Yeah, I'll invest in that all day long. I could care less what it costs because I know I'll get my investment back. The caveat there is you have to use it. You know, too often I see people buy it and they don't really have a plan of action. And that's where I come in as the national director, is follow up, making sure they're implementing it, making sure that they're satisfied with what they're seeing and understanding it. I was just on the phone yesterday and last week with some doctors that they're new to it, and so they're learning it. And getting repeatability, that's probably the biggest challenge that I see with new users. It's, you know, you'll get a different measurement if the patient changes position, just like the x-ray will look different if they shift. So learning how to have the conversation with the patient to direct them through the procedure. Now, you got to see a really special demonstration in Florida with a young man who I think it was like 4, maybe 3 years old.
So cute.
And I remember it was, so I was in Ben's practice in January. We did his install in January. And then I was in Kevin's in February. And when I did Ben's, we just worked on Ben and I think his assistant, but like he was all over it. And following up with him last month, he said, I'm using it every day. I love it. Now, when I was in Kevin's practice in February, we saw several little young patients. And, you know, that was his concern, is can a child follow the instructions enough to where you're going to see what you need to see? And really with rhinometry, it's easy because it's like pause your breathing.
Right.
And 5 seconds later, you've got a measurement. The pharyngometer is a little bit more difficult for a child to do. Number one, the mouthpiece is built for an adult. So we're considering making a smaller one if we're going to use it in the children. But even that little guy at 4, he put it in his mouth. Like he used the one that I was going to use on myself. So I had to dig out another one. That was kind of funny.
Yeah.
But it's we take a baseline measurement to see, you know, what the airway normal size is when there's airflow. And then we do a collapse test where we simulate what the absence of breath would be like, or really more of almost absence of breath. So in medical, that's called hypopnea. So we have them blow off one single breath and then indicate, usually with their pinky finger, when they're just about to get rid of all the air, and then we'll see the collapse happen. From there, it's just testing different positions with that same collapse test to find out, is there a jaw position that helps them? So I always say, think about CPR. You know, what do you do to open the airway in CPR? It's tilt the head, lift the chin. And that's exactly what we're doing in oral appliance if we're going to use it that way.
Right.
Now in orthodontics, what we're doing is the rhinometry, because as we do transverse expansion and we get anterior, posterior growth and development, well, number one, you got to get established nasal breathing and you have to have lip patency. But what we're seeing is as they turn those screws, we're getting the expansion, but we need an easy radiation-free way of quantifying that what we're expecting to happen is actually happening. And, you know, sometimes if we, in your world, if we just started with the myo and the nasal breathing and the lips together and the tongue position, that alone can sometimes get improvement and reduction in turbinate size. We can see on the Echo Vision whether it's a seasonal allergy that we're dealing with, you know, just a kind of an acute rhinitis that's happening, or whether it's a chronic condition. Maybe there's a polyp, maybe there's a deviated septum. But the question then becomes, do we need to address it?
Right. I just think it's so cool how quick it is. I
Yeah.
mean, to be able to know all of that in such a short period of time, it's easy to explain. I mean, you did it with a 4-year-old, so the fact that you can do it with anybody really at any age, I think is pretty incredible.
And
And
I also think I would add to that it's great that an assistant or a hygienist can do it. It's not something that's regulated.
right.
It's just a measurement. So
And I know you're going to be sharing your screen. We're going to get a live demo from Dr. Harrison here.
sure.
For those of you that might be listening on the podcast platform, you can head over to our YouTube page, CT Oral Facial Myology, and we'll make sure that we post this episode on the YouTube page so you can actually see everything in action. And I can see your screen, Dr. Harrison, so you are good to go.
Excellent. So we had opened this just a little bit earlier. So I just went into a demonstration mode, basically. And on the screen, we've got a graph, and on the bottom is the distance that we're measuring. So the first blue line, if we look down at the distance, it says 0 centimeters. So that's going to be where the tip of the instrument touches my nostril. Between the two blue lines, so if we look off to the right side, there's a secondary blue line at 6 centimeters. That's the average distance of an adult's nasal airway. Within those two blue lines are 3 patterns of lines. I usually call them diamonds, but they're markers, they're anatomic landmarks. And the first one is the nasal valve. And if your audience is aware that nasal valve collapse can be an issue, and we need to use nasal dilators or some form of support for that part of the airway. The second one is going to be the anterior limit on average of the inferior turbinate. And the last one is the posterior limit. So we're measuring the distance from the tip of the nose back to where the nasal and oral pharynx come together. So I've got the nose tip on here. There is a right and a left side, but it's probably too hard to see. I don't even know if they can see me on the screen or if it's just my screen. So what I'll do is I'll pause my breathing. I'll start the instrument. And then in like 5 seconds, we'll have a line that shows up on the screen that measures my airway. So this is my left nostril. There we go. I can advance the graph now and take the right side. So same thing, just pause my breathing when this tip touches my nose. There we go. Now, if I had been breathing, the line would have gone up and down because the other axis on the left is the size of the airway. So if they're breathing, our airway is flexible, it's elastic. And so if air is moving, it'll get bigger or smaller. Think of like a little circus animal balloon that a clown would blow up and turn into a poodle or something. If you blow air into that, it gets bigger. And if you let go of the end, the air comes back out and it gets smaller. So that's the best analogy that I've heard of. Now, if we compare the left and the right, we can see that they crisscross right after nasal valve and right at the anterior limit of the inferior turbinate. So that's a deviated septum. So if the right side gets bigger, the left side's got to get smaller, and vice versa. So that's an easy way to find information on what you could probably supplement looking at your cone beam volume of data later on. So I would know at approximately 2 centimeters, look for a deviated septum. I would know, look at 3.5, 4 centimeters, that it probably comes back, and just verify it. A lot of studies have been done that quantitate and validate the technologies against each other. Do we see the same thing in cone beam that we see in rhinometry? And that to me is interesting. But how quick was that? It was super fast. I mean, I couldn't set a patient up in a cone beam machine and take a scan in that amount of time. Like, it would take 5 minutes probably. So the shapes of the anatomic landmarks, those are measurements that were done by a sleep physician named Dr. Atul Malhotra. And he was at Harvard when he did these measurements, so not too far away from where you're at up there. And these were statistical averages of an adult population. As we move to the younger patient, what was interesting also last month in Florida is, even though that kid was 4 years old, is he hit the markers, which I wasn't expecting. I hadn't used this a whole lot on children other than, doing some recent installs in pediatric driven practices. But listening to Brett, he's kind of gone through the orthodontic literature and came out with some numbers to be looking for. And so what we're doing is trying to gather this data, and really, when you put the patient in and you put the age in, move the markers to be appropriate for the patient. The other thing that I've noticed with working with orthotropic offices is what is normal or common is maybe not ideal, because just a little bit of expansion and establishing nasal breathing, we're seeing these lines go way higher on the graph than where the averages are. And for me, I think that's the exciting thing, is being able to track your progress, being able to see as we do grow healthier jaws and establish better habits, that ideal could be much bigger than what normal is on this graph.
Now, how often do you recommend, and we're actually going to have Dr. Christensen on, I believe next week, we have a podcast scheduled, but how often, I'm really excited. How often do you recommend that? So you obviously are taking it as a baseline, and then how often throughout their expansion process do you typically recommend doing it?
So the couple questions I want to unpack there. So how often would I use this? I think the very first place you're going to use this in every practice is a new patient experience. I think just put airway as part of your exam. And I would even put it before you start looking at teeth and gums and everything else that you're used to doing, because if you're going to change anything, something's got to change. And if you keep doing things the way you always did it, you're going to be stuck with what you always got. So I would make an airway the umbrella of my treatment planning. I think it leads to more dentistry. I think it leads to longevity of the dental restorative treatment that you do. And it puts that patient in a mindset that this practice is different, and it leads to more referrals, honestly. Now, when we talk to orthodontic practices, they're going to do it on a new patient exam for orthodontics, and then they're going to do it through progress checks. So if they're expanding, it's probably going to be, you're seeing the patient in a month, or you're going to see the patient in 2 months. Do it while they're actively expanding. And then once they're done expanding, probably do it at 6 months. To verify that they're still have nasal breathing happening and they're able to breathe through the nose. You're also going to pick up different seasons if you live in an area where that will change. And then I would do it at a year follow-up. And I think that is also Brett's protocol, but we'll find out next week, I guess, for sure. In a practice that isn't doing orthodontics, I would do the baseline on a new patient. I would do a collapse on a new patient. And that's it. That's part of the screening. It's an airway screening. It'll take you just a minute or two. And if you couple that with all the known risk factors and comorbidities, you'll start to really quickly realize that when the data right now says, 1/4 to 1/3 of our population in America has obstructive sleep apnea, it's probably, in my opinion, closer to 50%.
Yeah.
So I kept data from 2007 to 2017. And what I found was 2/3 of my practice needed their sleep evaluated further. And of those that got tested, which was about half of them, every one of them had a diagnosis of obstructive sleep apnea. Which takes more years off your life than smoking. It's more dangerous than texting and driving. It's more dangerous than driving drunk. And if you put all three together, you're pretty much guaranteed you're going to kill yourself and possibly somebody else. But the other side of that coin is, well, if you've already been practicing and you haven't been doing anything with airway, how do you introduce this to your existing patient base? And a lot of dentists, I think, fall into this rabbit hole of conversation in the hygiene chair. And this makes the hygienist upset, because now you're 20 minutes behind, 30 minutes behind. Pretty soon you don't get lunch. Then you're late, getting out of the office at night, and you got to turn around and come back the next day. So
nobody wants a hygienist angry at them.
Oh yeah, you never want to upset your hygieniuses. That's what I called mine.